This is Articulations Chapter 9, and we're going to be covering Objectives 15 and 16 from Module A3. But again, remember that this material will be tested on Module A4. So we've already looked at joints and how joints are classified, and we're going to continue by looking at the types, the range of motion associated with the diarthrotic joints. So if we look at types of dynamic motion, we can imagine three types. We have a linear motion in which two bones glide. We have angular motion, and we have rotation. And all of these can be found on the various figures associated with your textbooks, specifically figure 9-2, where it looks at linear motion, angular motion, rotation, and it also looks at a fourth known as the circumduction motion. Not only can we look at dynamic motion, but we also can consider the planes or the axes of dynamic motion. If an articulation permits movement along only one axis, it's referred to as monaxial. For instance, in the pencil model from figure 9-2, monaxial would be the articulation permitting only angular movement in a forward or backward plane, preventing any movement other than the rotation around its longitudinal axis. If the movement can occur along two axes, the articulation is biaxial. And then lastly, the most mobile joints permit a combination of angular movement and rotation, and these joints are said to be triaxial. It probably makes more sense if we were to continue, or if you were to reference the book. So here we have, in figure 9-2, we have the initial position, a pencil at a right angle to the surface, and we see that linear motion, or gliding motion, is when the pencil remains vertical, but the tip moves away from the point of origin. And you can see here that the arrows are indicating both backwards and forwards versus side to side, if you will. Angular motion is when the tip remains stationary, but the shaft changes, the shaft of the pencil changes the angle relative to the surface. This is an angular motion. The circumduction motion is a type of angular motion in which the tip remains stationary while the shaft, held at an angle less than 90 degrees, describes a complete circle. And then in E, rotation occurs when the tip of the pencil is held stationary, but the shaft spins around its longitudinal axis, again is referred to as rotation. The types of movements found in synovial joints, they can either be described by the plane or direction of motion, or their relationship between other structures. In gliding motion, the two surfaces slide past each other. A good example of this could be found between the carpal or the tarsal bones. As these bones articulate with other carpals or tarsals, they then allow for gliding motion as they slide past one another. Angular motions can be described to include flexion. In this angular motion, you have a reduction in the angle between the elements. Again, this wording is kind of awkward, but if you think about someone flexing their biceps, you are, by bringing the forearm towards the head, you're reducing the angle between the forearm and the arm, and this is referred to as flexion. In the opposite direction, we can extend, and that's increasing the angle between the elements. Lastly, we have a hyperextension, and this is the extension that surpasses the anatomical position. So we see that, for instance, in this figure, here we have the two legs, and we would flex by kicking a leg out, reducing the angle between the leg and the body. We can extend by bringing the leg back into anatomical position, increasing that angle between the body and the leg. And we can also demonstrate hyperextension by kicking the leg back, and this is going to extend past the anatomical position. So flexion, extension, hyperextension, these are all used when describing angular motion of a diarthrotic joint. Abduction and adduction. Abduction, AB, removes or moves away from the longitudinal axis. So here's our longitudinal axis of the body, and as the arm is abducted, it's moving away from the longitudinal axis. Adduction is the opposite. It's where you're moving towards the anatomical axis. We see here that the arm, the leg, as well as the hand can undergo adduction and abduction. Down here in figure C, we even see how the fingers or the phalanges can be adducted or abducted. Angular motion, circumduction, can be demonstrated by the shoulder joint, as an arm creates a circular motion without rotating. We see that this is an example of circumduction. Rotation is a direction away from anatomical position. So we see that in anatomical position, the entire arm, which includes the arm and forearm, are extended out with palms facing anteriorly. As you were to rotate the arm inwards to where the palm is facing posteriorly, this is referred to as medial rotation. We see here medial rotation. And in the opposite, we can also laterally rotate by returning the arm to anatomical position. So rotation can be both medial, if it's going towards the midline of the body, or lateral rotation away from that midline or axis of the body. The head can also undergo rotation by simply denoting a left or right rotation, again depending on that person's left or right. Pronation and supination both reference the forearm, and this becomes very evident when you look at the movement or the changes that occur between the ulna and radius. In pronation, you rotate the forearm and the radius ends up rotating over the ulna. Here we have an example of pronation, and you can actually see, and I'm not going to draw over it, but you see the radius rotating over the ulna. In supination, you would be returning that forearm back to anatomical position, at which point the radius returns to its correct position during anatomical position. So supination and pronation. We have some special types, are movements associated with synovial joints. Inversion and eversion refers to twisting the sole of the foot. If you were to twist the sole of the foot medially, this is referred to as inversion. We see the the foot is twisting medially. Twisting the foot laterally is referred to as eversion. And dorsiflexion versus plantar flexion. You're actually flexing the ankle. In dorsiflexion, you are lifting the toes. So with this as your pivot point, as the foot is raised, as the toes are lifted, you are undergoing dorsiflexion, and plantar reflection refers to pointing the toes back down. So this is plantar flexion. I always think of it as you're planting your foot, you're planting your toes. Opposition is associated with the thumb. When the thumb moves towards the fingers or the palm, as if you were grasping, this is referred to as opposition. Protraction and retraction are both associated with the face. In protraction, you are extending the bottom jaw or mandible in a horizontal plane, pushing it forward, while retraction is returning it back towards its natural position. So pulling back. So retraction and protraction. Elevation, depression both deal with opening and closing of the mouth. Elevation, you're going to move in a superior direction. It's closing the mouth, while depression moves in an inferior direction or opening of the mouth. Lateral flexion refers to the bending of the vertebral column from side to side. Either way, whether you bend it one side or the other, it's both a lateral flexion because you're moving away from the midline of the body. These different types of movements, both regular movements and special movements, they are difficult. You really do have to practice. We will utilize some lab time in trying to make sure you understand how these ranges of motion, how these movements can be associated. Another way of classifying synovial joints is by shape. And you see here that we have 6 different types of shapes. Most of them, or some of them, can be associated with their motion, such as gliding. Along with that, we have hinge joints and pivot joints, ellipsoid joints, saddle, and ball and socket. A gliding joint, usually the types of articular surfaces you find with gliding joints, the articulating surface is flattened. You might have a slightly curved face, but you have a very limited range of motion. This can be exemplified by looking at right here we have the vertebral costal joints, in which you do allow some range of motion, or the clavicle, the acromioclavicular and clavosternal joints, in which you do have some type of gliding joint motion. Hinge joints create an angular motion in a single plane, so this is monaxial. Here we have the articulation of the humerus and the ulna, and you can see that the ulna you're only allowed or able to move your elbow in angular motion in a single plane, so it's monaxial. Pivot joints rotate on a monaxial axis. The articulation between the atlas and axis, or C1 and C2, allow for this type of movement. Ellipsoid joints, often you have one element that is has a kind of an oval articular face that sits in the depression of another element. And this motion allows a biaxial distribution. And of course we have some examples over here in this side of the table. A saddle joint occurs when you have 2 concavities. One bone straddles another, A good example of this is found within the first carpal metacarpal joint between the carpal and metacarpal on the first digits. And then lastly, we have the ball and socket. This is when a round articular face sits in a depression, and we can identify this both in the shoulder joint between the humerus and the scapula, as well as the hip joint between the femur and the os coxa. So again, we mentioned that a joint cannot be both mobile and strong, and we identified that relationship. As mobility increases, the strength of that joint decreases. The greater the mobility, the weaker the joint. Our mobile joints are heavily supported by other tissues, by muscles and ligaments. You do not have the bone-to-bone connections because it's just not strong enough. Plus, the friction created by bone-to-bone connection is greatly increased. The next couple slides just show some examples. And again, the objective of this module, or this portion of a module, is just to give a broad overview of joints. You need to know how joints are classified, also the range of motions and how the types of mobilities that different joints have. So I'm going to go through some examples now. I just need you to identify and be able to understand what's going on, but not focus on the joint itself. Before I do that, I want to talk a little bit about the intervertebral disc. This is that fibrocartilage that separates the body of the vertebrae and the backbone. These discs, these articulations, are often prone to damage. We've also often heard of individuals who have a slipped disc. This is when you actually have some type of damage that creates a bulge in a structure known as the annulus fibrosus. And this bulge can invade the vertebral canal and actually put pressure on the central nervous system. A herniated disc is one in which you actually have a rupture of the annulus fibrosus. And the substance that fills these little pads is known as the nucleus pulposus. And when that substance breaks through the annulus fibrosus, you end up with a herniated disc. And that herniation can easily press on either the spinal cord or the nerves, depending on its location. Here we actually see a pinched nerve. And again, this is due to the actual herniation of that disc. We're now just going to go through some examples. The shoulder joint, you have all the text here. I'm going to just kind of look at it. Again, what we see is a tremendous amount of support. And we would expect that because this joint is highly mobile. We have tendons and ligaments and all types of bursae and other accessory structures that are used to help stabilize this joint. Here's another view of the shoulder joint. Again, we see all the cartilages associated with that. The elbow joint, again, it's a relatively mobile joint, and we have a tremendous amount of ligaments that are helping to stabilize this joint. Here's your hip joint. We note the acetabulum of the os coxa, and a number of ligaments that are associated with this structure. The knee joint, again, fairly mobile, and a number of ligaments associated. We often hear about tears in the anterior cruciate ligament, the ACL. Here we actually see the ligament. We see it here from an anterior view. It's a ligament that helps to stabilize the femur to the tibia, stabilizing the joint. And this can easily be torn in certain sports injuries. And and often requires surgery to replace it. In Table 9.4, you have a summary of all the articulations, or many of the articulations of the appendicular skeleton. Again, it describes the element, the joint, the type of articulation, and the movement that is responsible or capable. One of the last objectives of this section deals with aging. What happens with to our joints with old age? And I think if I were to ask, a lot of people could come up with stuff like arthritis. Let's just kind of define some of these terms. Rheumatism is any type of pain or stiffness of the skeletal or muscular systems. So rheumatism is a very generalized term that just identifies pain or stiffness. Arthritis deals with actual damage to the articular cartilages of the synovial joints. We can subcategorize arthritis into osteoarthritis. You should identify osteo as bone, and this is caused when you have wear and tear on the surfaces of the joints. They can be genetically linked in the formation of various collagen fibers, and we often see osteoarthritis in older individuals. Here we actually see some damage that is caused by arthritis. I found this image online, but you can just kind of look at it. We have some damages here. We have the knee joint, and we see the patella, and we see degeneration of the joint surfaces as this articular cartilage is damaged. The bone starts rubbing on bone, and it creates problems. Rheumatoid arthritis is an inflammatory condition. It can be caused by a number of things: an infection, an allergy, or an autoimmune, in which your own immune system actually attacks the structure. In rheumatoid arthritis, the immune system attacks and helps it destroys some of the tissues associated with the joint, and that can lead to inflammation and other problems. Gout, or gouty arthritis, occurs when waste products or any type of excessive byproduct in the body build up and they crystallize. Usually gouty arthritis is associated with uric acid, which is a waste product, or calcium salts. When there is excess of these substances in the body, they can crystallize, and you end up getting crystals within the synovial fluid, and this can cause a tremendous amount of pain and inflammation due to the fact that the crystals are present. There are metabolic disorders associated with gouty arthritis, and we're not going to get into them now. We'll cover them in a later, probably next semester, when we look at the metabolic disorders. But gouty arthritis is definitely something that most people are somewhat familiar with. Gout. With age comes joint immobilization. Basically, the synovial fluid flow is reduced. It can cause arthritic symptoms. If you do not have the synovial fluid creating a barrier between the two bones that are articulated, you can end up with increased friction and then all the symptoms that would follow. Joint immobilization is treated by continuous passive motion. Often the elderly who suffer from this type of condition, the way to treat it is to continually move those joints. I've seen elderly individuals who have been hospitalized have therapy in which individuals come in and help them move their joints to help reduce or help to increase the flow of that synovial fluid. Other symptoms associated with aging include a bone mass decrease, weakening of the bone, and of course these are all going to lead to increased probability of things like hip fracture, dislocation, or pelvic fractures. Remember that bone is constantly being remodeled and recycled. Living bone is broken down and new bone is being produced. And we talked about the osteoblast and clast activity last module. Other factors that affect bone strength include physical stress, certain hormone levels. Again, we're talking about the antagonistic relationship between parathyroid hormone and calcitonin. Calcium and phosphorus uptake can be an issue. We linked this to vitamin D3 and ultraviolet radiation. There are other things that can deter calcium and phosphorus uptake. And of course, there are always genetic and environmental factors that affect bone strength. Integration with other systems. The bones of our body support the weight of our body. Okay, they protect vital organs. They store fats, they store calciums, they store phosphorus, and they also play a role in the manufacture of immune cells. Some of the disorders that other body systems can cause include tumors and osteoporosis, arthritis, and rickets. We've discussed most of these at some point in the last two modules. That ends the section on Chapter 9, Articulations. Again, I'm not looking for the specifics of individual joint structures like the hip joint or the shoulder joint, but you do need to understand how joints are classified. You need to know the specifics of the synovial joint with all of the accessory structures. You need to know the relationship between mobility and joint strength. As mobility increases, the joint strength decreases. And you also need to know some of the different types and classifications of the synovial joints, especially as they are related to the range of motion.